Good afternoon. Welcome once again to our webinar series entitled Frontline Report on COVID-19 Vaccines. This webinar series has been made possible via collaboration between the Autoimmune Hepatitis Association and the Center for Autoimmune Liver Disease and Cincinnati Children's Hospital. My name is Frank Lambert. I'm the Executive Director for the Autoimmune Hepatitis Association, and I'm also an adult hepatologist at Indiana University. I'm excited to introduce you to this webinar entitled A Family Affair: Information for Kids, Teens, and Parents. But first, a disclosure from the AIHA. This series does not replace your primary physician, gastroenterologist, or hepatologist. We cannot diagnose, treat, or manage symptoms associated with AIH. We believe any changes in the treatment or therapy should only be done under the supervision and direction of your treating doctor or care team. In this webinar that has a pediatric focus, but information relevant for everyone, we are lucky to spend time with Dr. Robert Frenck, a professor of medicine and infectious disease expert at Cincinnati Children's Hospital. He's an extremely well-published clinical scientist, chairman of the local institutional review board, a principal investigator of an NIH-funded vaccine unit, and has led and completed numerous clinical trials with vaccines targeting a variety of viruses and bacteria. Despite seeing less frequent severe or even symptomatic novel coronavirus infections in children, still, there are many pediatric considerations relevant in the era of vaccination and new coronavirus variants. Our members have made that clear, and we've collected a number of member questions to help clarify these key points. Not only are these issues relevant to children with autoimmune liver diseases, but include all children and even their parents in the year to come. Moderating our discussion today with Dr. Frenck is Christine Browner. As many of you know, Chris is a very strong advocate for pediatric autoimmune liver disease research and education through a number of organizations. As a parent to a son with autoimmune liver disease, she has seen firsthand the challenges the pandemic has brought to those affected with these illnesses. Thank you again for joining us, Chris.
Dr. Lambert, thank you so much. I'm really excited to be a part of this conversation. I have, as a parent of a child with PSC, primary sclerosing cholangitis, and autoimmune hepatitis, I have a lot of questions about the vaccine myself. So, Dr. Frenck, thank you so much for being here and talking to us. And if you're okay with it, I'm just going to jump right in with some more general questions.
Please.
Okay, so we know that there's lots of different sort of vaccines out there that are coming to market. And I'm wondering if you could give us a short overview of the vaccines that are currently available, kind of how they work, and maybe how effective they are.
Sure. So, I mean, one of the things is that with the vaccines we have against COVID, that they all are working on the same principle as trying to develop an immune response against a part of the virus called the spike protein. And so if you've seen cartoons or pictures of the virus, on the outside of the cell, these little protrusions, those are the spikes on the virus. And those spikes is where the virus attaches to our cells and then is able to get into our cells. So if we can make antibodies that block that spike protein, then the virus can't attach to our cells and cannot infect us. So right now in the United States, there's three main platforms that we're testing for COVID-19 vaccines. The first one is what's called an mRNA vaccine, and M stands for messenger. And RNA is basically if you think about it, our blueprint for what we use for our own genetic material, what the virus uses for its genetic material to make new things. So in our own body, whenever we have a cell that needs to grow, to differentiate, to make a new cell, we tell our DNA to make RNA, and then our RNA is translated into a protein. And then after it's done its job, the RNA is degraded or chewed up and is gone. So with the mRNA vaccines, what we've done is very clever and very smart scientists have identified the gene for the spike protein, and that's the mRNA. And then they put a coat of fat around it, because if you didn't, that mRNA would get chewed up before it ever made it to the cell. But that mRNA with the fat around it is the vaccine. And then when that mRNA gets into our cells, then the rest of the vaccine is basically our cellular machinery taking over. So our own cells use what's called our tRNA, our transfer RNA, to make the protein. And then we put the protein on the surface of our cells. And it's basically like waving a flag saying that this is abnormal, come attack me, and make an antibody against me. And so that's the way the RNA vaccines work. The other main platform is what's called an adenoviral vectored vaccine. And so adenovirus are very common viruses that rarely cause more than just a cold. So that in a wild type, so just an adenovirus that we can find in the community, if you're really severely immunocompromised, an adenovirus can make you sick. So I can imagine people that are having hepatitis problems, and they say, oh, I don't want anybody to give me an adenovirus vector vaccine. It's going to make me really sick. Well, these adenoviruses have been modified so they can't grow in the body, that they can only grow in a cell culture line. These adenoviruses, then, what we've done is the same thing as for the mRNA vaccines. What we've done is we've taken the gene for the spike protein and put it inside the adenovirus. And then the adenovirus is what our vaccine is, and that's what's injected into us. And then when that adenovirus gets into our cells, it breaks apart and it releases that spike protein gene. And then the rest of it is just like I was telling you about the mRNA vaccines. And then the third main type of vaccine is a pure spike protein, so that you're using a virus to make the spike protein, you're harvesting the spike protein, and you have pure spike protein that you're injecting. And that's similar to, if you will, like the typical flu vaccine that we've used, where we're using proteins that are on the outside of the flu virus. So those are the three main types. The one that's been, the two that have been approved for use in the United States right now are the mRNA vaccines, the Pfizer vaccine and the Moderna vaccine. And those were approved using what's called an emergency use authorization. And what that means is that the FDA, the Food and Drug Administration, has sufficient information on the safety and efficacy of the vaccine to say, in an emergency, which is what we have, obviously, this pandemic, that we can start using the vaccine before it has fully completed clinical trials. And so that's why it's called an emergency use. The preliminary data from both the Pfizer and Moderna vaccines have been extraordinary, is that it's about a 95% efficacy against the infection. And that's one of the things people have to understand about that, though, is that's starting at 1 week after the second dose of vaccine. And so that you can't just get a shot and say, okay, I'm good, I don't have to worry about anything more. That's not true. Is that you need to get that second dose, and then it's about a week after that second dose is when we're looking at that efficacy. That there have been some sub-analysis that a lot of people have been talking about as far as, well, maybe you only need 1 dose of vaccine. We really don't know that, because that's not the way the studies were designed. They were designed for 2 doses. We do have some information between a week after the first dose until a week after the second dose to get some idea about maybe the efficacy of 1 dose, but that's really not how the studies were designed. With that small sub-analysis, it looks like 1 dose may give you about 60% efficacy, which is good. It's not 95, but it's certainly better than nothing. But we don't know how long that lasts. And that's why we really, at this point, are still saying we want to stick with that 2-dose regimen.
Okay. Thank you for that description of those vaccines. I'm really glad that there are very smart people working on this. When do you think children and teens are going to be eligible to get the vaccine?
So the Food and Drug Administration can only license vaccines for which they have data. So right now, Pfizer has gone down to 12 years of age. That we actually, at Cincinnati Children's Hospital, were one of 5 sites in the country to ask to be testing the vaccine initially in the 12 to 15-year-olds. They're now expanded the number of sites, but we were asked to be one of the first 5 to make sure that the vaccine was safe and immunogenic. We've also been one of the ones testing in 16 and 17-year-olds. So I think Pfizer will have right now their EUA is for 16 and above for Pfizer. Moderna is 18 and above because they have not done trials in children yet. I think that the vaccine will be licensed for children 12 and above before the start of the 2021 school year, because there are going to be sufficient children 12 years and above that will have been tested. I'm not sure as far as with Moderna or AstraZeneca or Janssen if they'll have that data or not, but I'm pretty comfortable that the Pfizer vaccine will be licensed for 12 and above.
What about children that are younger than 12?
So what we have to do is, like I said, is to kind of, we have to gather the data. And so what we've been doing with COVID vaccines is looking at who is at the highest risk. And that's the group that we're targeting first. And so the people at highest risk are people over 65, and every decade the risk increases. So that 75 is a higher risk than 65, 85 is a higher risk than 75. And so that's the group that we wanted to test first, so that we could protect the highest risk group, and then marching down in age. From a regulatory, from like the requirements or the law, the guidelines, if you will, for testing vaccines or drugs in the United States, and pretty much the same kind of ideas in the world, is that for having trials for children, you have to have a prospect, a potential for direct benefits. So we really needed to, so that that child is participating in the trial has some potential for having benefit by being in the trial. And so that's why getting the information in adults first is also another important thing, because now we can come back and say, look, we have evidence that in adults that this vaccine is 95% effective. And so there's a good reason to suspect it would be also very effective in children. So it's, while there's always a risk to be in a clinical trial, we've shown that there's a lot more potential for benefit now. So that's another reason starting in the adults, to gain some information about safety and efficacy. And then, you know, so marching down, as a pediatrician, I've been doing pediatrics for almost 40 years now. If this virus isn't shared from children to adults, it'll be the first virus in respiratory virus that I've seen that kids aren't passing it to adults. I think what's happening is that children just on the whole aren't getting as sick as adults. It's not that they're not getting sick, but their severity is a lot lower, or the likelihood of getting severe illness is a lot less. But it's not been zero. We've had over 2.5 million children in the United States so far that have been infected with COVID. We've had over 9,000 children hospitalized because of COVID, and we've had about 175 perfectly healthy, normal children until they got COVID that died from COVID in the United States so far. So while children are at a lot lower risk, it's not zero. And then so that's why we are thinking that we need to go down in ages to testing. My guess is we'll probably go down the lower range of somewhere between 3 years and 5 years, potentially eventually going lower than that. But I think the first thing is if we can get kids at ages where they're more likely to be going to daycare or school and above, and have vaccines for them, that would help a lot in decreasing transmission.
So most immunizations, like measles, mumps, and rubella, protect from diseases that are much more severe in children than adults. And that's opposite for COVID-19, right? So, which usually produces mild or no symptoms, like you talked about, in children and young adults. So why would parents then, why should they immunize their children against COVID?
Well, one is the thing, maybe just to talk about vaccines in themselves just real quickly, is that one thing people don't remember is that in 1900, 1 out of 5 children died before they got to 5 years of age. 20% of children died before they got to 5 years of age. And that was because of these diseases of childhood, because of measles, because of rubella, because of Haemophilus, pneumococcus, flu. And so people don't realize how severe those illnesses are. So it's not that the diseases are less severe in adults than they are in children. It's that basically adults typically are immune because they've already had them as a child. But if you get chickenpox as an adult, you actually get much sicker than if you had chickenpox as a child. Or if you have mumps as an adult, you can get much sicker than if you have mumps as a child. So it's not that the diseases are less severe, it's just that most of the times the adults have already been immune, either because they've been vaccinated or, when I was growing up, because they had the diseases already. So why do we want to vaccinate kids, though, against COVID? I think there's 2 reasons. One is what I was mentioning before, is that the kids are getting infected. And so it's to try to have a direct benefit for the child. But I also think that one of the things that could be happening is that by vaccinating kids, we can decrease the spread to others. Now, we're still looking at that to see how well the vaccines prevent spread, but we do have a lot of other vaccines where they do prevent spread. Flu is a great example. If you immunize children against flu, you can have significant decrease in the amount of disease in adults because the kids aren't bringing flu home to the parents and sharing it with them. So those are really the two reasons I think that you need to immunize children. One is to protect them themselves, and then two, as far as if they don't have it, then they're not going to be giving it to their parents or grandparents. And if you think of our society now, is that many parents, both parents are working, and well, mothers are always working, but that both parents are working outside the house, and so that oftentimes then grandparents are the ones that are watching the kids. And then who is at the highest risk of getting severe disease? Grandparents. And so that the kids could inadvertently be bringing something to their grandparents. They don't even realize that they had COVID, and then the grandparents are getting sick. So that's really the reasons I think that it's going to be important to immunize everyone.
Yeah, those are excellent points. And you mentioned earlier that perfectly healthy children still have been admitted to the hospital, and even some have died from this disease. But I feel like in the news, we're not hearing as much about that inflammatory syndrome that we were hearing about originally. Is there any new updates on that, or is it because there's a new treatment for it?
So MISC is which calls the multi-system inflammatory, is that it's basically very similar to a syndrome called Kawasaki's. And at first that we were really just thinking we were having an uptick in Kawasaki's, and that Kawasaki's is a syndrome of you're having the fever, you're having the red eyes, the cracked lips, you're having a swollen lymph nodes, rash, that we don't know the specific etiology. In a lot of ways, so the specific cause. In a lot of ways, I think MISC is Kawasaki's, where we have more of an idea of what the cause is, so that caused by a coronavirus. And so that our immune system is set up to try to kill off an invader, to kill off a virus, to kill off a bacteria, kill off a fungus, whatever. Occasionally, it can get confused and it attacks ourselves, and that's when we have autoimmune diseases. But also sometimes it gets too robust, it gets too aggressive in its immune response. And that's pretty much what MISC is that our immune system is being too active. And so that we're really, really revved up. And that's why the treatments that we've been using are the same treatments we're using for Kawasaki's, is like using steroids and IVIG to try to calm down the immune system. So we don't have a specific treatment for MISC. We are still seeing cases of it. It's the cases of MISC you're going to see are the cases of MISC that will occur are going to be based on a percentage of the total COVID. And it happens typically about a week or two after a case of the COVID. So it's not with the acute infection, it's more our immune system is getting revved up and continues to be aggressively fighting something. And so that we tend to see those symptoms, the MISC, about a week or two after the acute infection. So that as we're seeing spikes in cases of COVID in children, then a couple weeks later, I wouldn't be surprised that we see spikes of MISC. But what can happen is in the media is going to be presenting things that are different, are new, are cool, are intriguing, things like that, because that's what's going to catch your attention. That's what's going to get you to buy a newspaper or watch their television program or stay on the internet or whatever. So they need to have kind of a cycle so that after you've saturated with one thing for a while, they're going to let that go until something changes on it again. So I think that's what's happening with MISC as much as anything.
Okay, thank you. Dr. Frenck, are there children at particular risk for COVID-19 complications that we should prioritize for immunizations once it's approved in children?
So it would be people that would be at risk, higher risk would be in children would be ones that would be at higher risk for any other kind of bad viral disease. So if you're having problems with your T cells, that's the bigger problem for viral infections. B cells a little bit. So if you have immunocompromising, you could be at increased risk for COVID. The risks that we've seen for adults otherwise have been high blood pressure, heart and lung disease, diabetes, and those probably are cofactors for the age then too, as we're getting older, that we have had kind of an accumulation of injuries to our body over our lifetime, and they all together make it of a higher risk. So I think in kids, the biggest group would be probably T-cell disorders, and then high dose steroids are things where you're giving to them because you're needing to suppress their immune system for their underlying disorder. But then that also could put you at more risk for a viral infection too.
Okay, thank you. We've also heard in our disease community that there's some concerns that one of the long-term effects of this vaccine may include fertility problems. Mm-hmm. Should young men or women be concerned about that?
So unfortunately, there's a few people in our society that like to perpetuate myths. For whatever reason, that they perpetuate myths. Infertility and COVID vaccines is an absolute myth. It's untrue. There are no data to show that at all. And that's about the best I could tell you. One of the things, if you think about it, is that we've only been testing COVID-19 vaccines since about May. So only about 7 months ago. So if you think about it, an average gestation is 9 months. And so even if everybody that started to want to get pregnant got a vaccine in May, we only had a few hundred people that would have received the vaccine at that time. So basically, from a logical standpoint, you can look at it, it's impossible that anybody would have any data about fertility. This is just made up. It's just a hoax. It makes people nervous. And so it's a way that they can get people to not be vaccinated. It's unfortunate that people are doing things like this, but for some reason, some people seem to want to do that. But I can tell you, there's fertility problems, not a problem. Some of the other things people talked about is that we don't want to get the vaccine because it can integrate into our DNA. That's absolutely impossible. That the virus, like I said, can't replicate for the adenovirus in the first place. And then the RNA does not get out of the cytoplasm. So the nucleus is where our DNA is, and the RNA cannot go from the cytoplasm, which is the outside of the nucleus, into the nucleus. So it can't even get to the DNA in the first place. But secondly, it can't incorporate. And third is that this mRNA is very short-lived. It's only about 2 or 3 days, and then it gets broken down. The other things that we've heard people say is that I don't want to get the vaccine because it's going to give me COVID. That's not true either, is that we do not give the whole COVID virus. We're only giving pieces of that spike protein gene for our body to make an immune response. And that people have said, well, if I get the flu shot, that'll protect me against COVID. That's not true. And also, if you get the COVID vaccine, it does not protect you against flu. They're two viruses, but they're two totally different viruses that need their own individual vaccine. So there are a lot of rumors out there. Unfortunately, people have been ready to make up rumors, and that's a lot of the reasons why I'm doing these kind of presentations, to try to give people the facts. And that the internet is a great place to get information, but the problem with it is that it's unfiltered information, and sometimes it's hard to know who's saying this and what kind of reliability they have in the statements they're making. But fertility is not an issue with COVID vaccines. There are no data to show that the COVID vaccine would affect fertility at all.
Thank you for so clearly dispelling those myths, because those things definitely circle around, like you said, on the internet, and we hear these things that aren't true. So I appreciate you being so clear about that. I would love to switch gears a little bit and ask you some questions about the new variant that we've been hearing about. So it's been reported that this new variant of COVID-19 that was first found in Britain could soon be the main variant. It's more contagious among the general population, among children. And can you share more about this new variant and what impact it will have? And should we see an increase in the number of children getting COVID?
So coronaviruses are RNA viruses, just like a flu. And the reason that that's important is that RNA viruses like to mutate, like to change. They do that routinely. And a mutation is the way that a virus or adapts to be able to survive in the environment. We mutate too over time to be able to adapt to our environment. So that you have some mutations that give a selective advantage to a virus or a bacteria, and they're going to stay in the virus. There's ones that can actually be deleterious to them, to kill them, and so those mutations are lost. So that having a mutation is not something people should be surprised about. That's normal. The one thing about the mutations, though, is that it depends on where they are and what they're doing as far as what they may do as far as the ability of the virus to be attacked by our vaccine or protected, our vaccine to protect. Right now, it looks like is that even though you're having some changes in the spike protein, the changes that they're having have not affected the ability of the antibodies to attack the spike protein still. So that you can only you can have changes in the conformation of the spike protein a little bit, but if you make too big a changes in the shape, the conformation of the spike protein, it won't be able to fit into its receptor on the cell. So that's one of the things, is that receptor and binding is almost like a lock and key. So if you change that shape of the spike protein too much, it won't fit into in the receptor on our cell where that virus normally attaches. So that's one of the things, is that if you change that spike protein too much, that's actually a lethal mutation for the virus. So the point is that the vaccine, they have tested in vitro in the laboratory against many of these different mutants. So both Pfizer and Moderna. I don't have data for AstraZeneca or Janssen, but I can tell you from Pfizer and Moderna, they've tested in the laboratory these different variants, and the antibodies have blocked these different variants. So even though that there are variants, the vaccine still at this point looks like it's working well. So if anything, what I would say is that having the new variants is even more of a reason we want to go get vaccinated, not less of a reason to get vaccinated.
That's great news. That was a real big question of mine, of whether the vaccine would work with the new variants. So that's good to hear. I'm wondering, are there concerns that any of the vaccinations that are currently approved or under evaluation, that can they cause or even worsen immune conditions? I know that's a big concern in our disease community.
So I will say no, and then I'll tell you why I think it's a no. So first of all, the mRNA, there's no cells with it, it's not alive. It's just the spike protein gene. And it's a very short-lived material. It's about 2 or 3 days and it's gone. Is that what the job of that mRNA is to do, is to make the spike protein. And so once it's made that spike protein, our body's putting that spike protein on the surface of our cells to start our immune response, and then that mRNA is degraded. If you think about it, is if you say you had COVID, God forbid anybody gets it, but if you were to get COVID, what our body does is break down the virus, tries to chew up the virus, and then it makes antibodies to different parts of the virus. And one of the things it does in a natural infection is make antibodies to the spike protein. So what we're doing with the vaccine is simulating what would happen with a natural infection. So that if you were infected with COVID, or if you were given a vaccine with COVID, both of them are going to give you antibodies to the spike protein. So that it's not that we're doing something special, we're just doing it in a safer way than everybody getting infected with COVID. So that one of the things people have talked about, you could get herd immunity. And so that meaning if you get enough people infected, that you can't transmit the virus from person to person anymore. Well, overall, the case fatality rate, so if you get a bad case of COVID, the likelihood of you dying is about 3% overall, the whole population. But we have 400 million people in the United States, 3% of that's 12 million people. And that's why I'm saying is that we don't want to get the herd immunity by having everybody get infected, because we're going to have a lot of people die that way. Mm-hmm. And so that's why the vaccines are so important. But the mRNA vaccines they're short-lived, their mRNA is degraded. There's nothing that persists in your body other than your antibodies to the spike protein, which you would have if you got natural COVID. You'd have those same antibodies, you'd have the same T cell response. So the virus gives you an antibody response. The vaccine is simulating that response without having you have to have the infection. For the adenoviral vectored vaccines, even though you hear the word adenovirus and that, they're really not something we should consider as a live virus because they can't grow, they can't replicate in us. They've been engineered in such a way that they need a compound to grow that is not in our body, so they can't replicate. And so their only job is to bring that mRNA gene into the cell so that, again, our body will make the spike protein. So the end answer, I would say again, is that I don't see any of these vaccines increasing the risk in somebody that is immunocompromised versus somebody that has a normal immune system. I also would say is that if people had any concern, they could say, I would prefer to get the mRNA vaccine. I don't think that's really necessary, but the mRNA vaccine, I can absolutely tell you, there's nothing to replicate. There's no cells there. There's nothing. It's just mRNA, and then it's gone in, like I say, about 3 days.
Do we know which cells typically take up the RNA or the adenovirus and then express the protein? I guess specifically for this community, do the liver cells?
The main thing is that it's in our muscle because that's where we're injecting it, and then they put that on our muscles are putting the protein on the outside of the cells, and then our antigen presenting cells, which are cells that are floating around in our bloodstream that see those, and that's where you're starting to make the antibody response. I wouldn't think they'd really be expressed on the liver cells, but I won't swear to you on that because I've never looked at that or thought about that. The main thing is that but they're injected locally into our muscle cells, and that's where the immune response is starting.
Dr. Frenck, thank you for educating us on this vaccine and kind of the future and where we're heading as a community.
Special thanks again to our expert guest, Dr. Frenck, as well as our moderator, Chris Browner. I know as a parent, Dr. Franck's input today is tremendously helpful, and I think it gives us a good frame of reference as we consider how our families are going to navigate the remainder of this pandemic. Finally, thank you to the collaborators of the AIHA, specifically the Center for Autoimmune Liver Disease Research and Cincinnati Children's Hospital. We hope you'll join us again for our next webinar. We'll see you then.